Alrighty, I'm back with you now for take two here. We started off, or excuse me, we left off with this image that we were talking about, contrast and density. And please excuse my voice, it's going in and out, but remember we were talking about the density of the patient. We know that the posterior region of the patient's head is much more dense or thick compared to the premolar region. If we expose the image with the same level of intensity or radiation, you're going to see this section of the film is a little bit lighter compared to this section of the film. Therefore, you wind up with some kind of radiolucent burnout. This is very indicative of the region that it's being exposed here. Remember, we were also talking about the calculus, and if we click on these images, it's going to show us some curious lesions, type 1, type 2, and type 3, excuse me, class 1, 2, and 3 in our calculus as we move along. Normal alveolar crestal bone following the pattern of the CEJ, and early periodontal bone loss that's present. We also look at this image here and we're noticing that this tooth looks a little different. So that should trigger your response to go look clinically to see why is it different. And then it would be charted on the patient's actual chart that the tooth is fractured. Compared to possible carious lesion here, we have some calculus, very irregular margins. We definitely have some radiolucent burnout here. Some significant caries, possibly a class 3 caries lesion, some overhanging margins, and recurrent caries. Why does that happen? Significant overhangs. When this restoration was placed, it created a very large seeping out of the amalgam material. Therefore, it creates like a shelf that harbors bacteria, and there's no way this patient can clean effectively without shredding floss everywhere. And so they probably get very frustrated and wind up shredding floss, therefore they choose not to do it. Other carious lesions as noted. Here we look at this image. It's a very good image as far as interproximal spaces are open wide. We have some decay. We've got possible in class 2 to 3 lesion here that we need to be aware of. It looks suspicious, with the shadowing here. We've got some radio opacities that are localized. This is possibly a little bit of maybe an older person. We're not quite sure. Sometimes they call these enamel pearls, but that is determined by the physician also. Amalgams placed in here, nice horizontal bone. This looks like vertical bone loss, but if you look at the way this tooth is positioned, it's depressed more in the socket, so it's actually following the CEJ as it normally would. So recurrent caries here and some periodontal disease. You'll see how recurrent means comes next to an already existing restoration. It had a history of having decay and now it's recurrent. As you progress through preclinic and clinic, you'll learn to use transillumination very effectively. Sometimes we don't always have radiographs for the anterior region that are current, whereas the teeth are so thin in these areas that you can shine light by transmitting your overhead light, bouncing it off the mirror face, projecting it through the teeth, and it will show you a radiographic lesion. Excuse me, not a radiographic lesion, a transilluminated lesion, which in this image, if I were just looking from the facial aspect, would look like a good class 3 type restoration. And this looks the same. As you see that the color changing here, darker, that's getting closer to the dentin of the tooth, compared to the edges of the teeth are very thin enamel, which is very normal, and you'll see the shading change between the teeth. So we do have a class 3 restoration here revealed with transillumination. I'm going to go ahead and click ahead so we can get a little bit more covered for us. You'll notice here, radiographically, this looks odd. So that should trigger a puzzling question in your mind. What is that? That doesn't look normal. So we're going to go look in the patient's mouth, correlate this to the tooth that it correlates to, and notice that there's some hypocalcification that's present. This is a fairly young person. You can see the teeth don't appear to be fully erupted yet. We have some very significant moderate gingivitis here that is creating the red swollen margins and more than likely very easy bleeding upon manipulation, even with the toothbrush. Here we go. We're looking at some anomalies of the teeth. Well, sometimes patients are born with genetic defects and or they were ill at a certain time when the teeth were forming below the gum lines. So this, if you looked at this patient and then you looked at the radiographs, you would discover that they kind of follow the same line. If you took a piece of dental floss and you kind of laid it out here, plotted it across, you would see that it almost would follow a line just like the rings of a tree. If you cut a tree in half and you looked at the rings, you could see and plot the age of the tooth. And you can almost plot a timeline here the same way. You can look at the patient and ask them, do you ever remember being sick when you were around 10, 11, 12, somewhere around there, and for high fever, any abnormalities that you remember? And more than likely they'll say yes. And that is caused by a disruption in the enamel matrix, and therefore they have an irregular shaped margins. That could be one of the reasons. The other reasons are many. You never know until you take an accurate medical history to determine what is up with the patient in their dental history and medical history. So the hypoplasia that appears on here, this tooth appears very irregularly shaped. Therefore, it would cause you to go and look clinically. Obviously, a significant carious lesion here at a weakened spot. What is normal periodontal structures? We're looking here. We have some nice horizontal bone that's present following the CEJ. The one thing that pops out to me on this image is this wonderful overhang right here. This patient's going to wind up with some serious issues if this is not remedied, or at least they take an active interest in keeping this area clean, because it will wind up harboring bacteria and collecting and destroying the bone matrix here. Moderate to severe periodontal disease. We won't spend a lot of time on this because you'll be learning more in periodontology next semester, and this is obviously something significant is happening with this patient. We've lost more than likely 15 millimeters of bone right here. Don't know until you actually measure with a probe. The only thing that's holding this tooth in is tissue, more than likely. And you know, we know that the prognosis is not very positive for this tooth. We would want the doctor to evaluate to make sure that this would more than likely be referred to a periodontist to evaluate for root fracture, and or if there's any other anomalies that are going on, to see if there was any way to regenerate the growth of this bone. Mesial migration causing some periodontal issues there. So on over to the next slide here, we have some furcation involvement. This looks like radiolucent burnout, but more than likely, given the age of the patient, you can tell there's significant horizontal bone loss here, that there's probably some cervical caries here. And we were right. Cervical caries, very indicative of possibly an older patient that's maybe on medication that has caused some significant xerostomia, and we wind up with a thick, ooey gooey biofilm that's present around all the cervical or neck regions of the teeth, which is very challenging sometimes for patients to keep clean. Overhanging margin, furcation involvement, some significant bone loss in this area. So those are the things that you really want to pay attention to. Even though this says horizontal bone loss, that first thing that you think of, horizontal bone loss, well, that's normal. This is not normal. We have significant what we call clinical attachment loss. Attachment loss is here at from the CEJ to here. We're probably looking just experience possibly telling me 6, 7, 8 millimeters of pocketing that, and we don't know until we actually clinically evaluate it with the periodontal probing measurement. We're probably looking at a class 2 or 3 furcation involvement here, but again, until we have verification through a clinical verification, we will not know. Sloping of the bone, remember 2-dimensional versus 3-dimensional. Same thing in this image. First thing that you should be looking is something's not right. What's not right? Here we have significant bone loss. Oh, we have a mental foramen. Wow, this is the perfect example. Do you see how we have a premolar here, fully intact white PDL here, no communication significant. This is a very isolated, non-circumscribed type or opening or foramen where the mandibular nerve exits. We've got something going on here that's got this tooth really angry. More than likely there's some separation upon clinical evaluation. If you don't know what that word means, it means pus. When you push on the side of the tooth, there's probably something ooey gooey going to come out of there because we have a significant defect right here. And if you trace it, it goes on around. Remember, you're looking at these images in the dark because it allows your eye to see the gray images more efficiently. So keep that in mind when you're always evaluating radiographs. Periodontal disease again continues. Periapical radiolucency surrounding this tooth. Something's not okay with this area, obviously. And the significance of this too is this is what we call a virgin tooth. There does not appear to be anything that is causing this tooth to do this. The only thing, the first thing that comes to mind to me would be to ask the tooth if they remember, ask the patient if they remember anything abnormal happening here. Did they suffer any trauma or blows to the head? Because, you know, we could have a fractured tooth, we could have a perioendo, we don't know. We just know this is abnormal. There is a lucency that's occurring here, and unless it's treated, it's going to wind up affecting both teeth on either side. Common anomalies, we have some calcification that's going on. This is very unusual. What do you see first? You look at it, it doesn't look. Where are the pulp chambers? Where is the canal? What's going on? We have calcified pulp chambers and a bifurcated root on a lateral, mandibular lateral. You'll see that is very uncommon. We have one here following and one here. Excuse me, clicked and didn't mean to. The same thing. Remember, we function in mirror images of one another, and this is more than likely the same situation. Here we have a vertical bone loss. Right here, some kind of irregular bone loss. These opacities are more than likely mandibular tori. We have a retained deciduous tooth with no permanent underneath it. So that brings out about, a real decision for this patient. Am I going to keep this for as long as I can? Do I need an implant? What do I need to do? Irregular discoloration, opacity in this region. And, oh my goodness, a 3-rooted mandibular molar. Very unusual. So you just never know what you're going to see. There are some film processing errors on these because these are actually scanned images of film-based products. I'm going to stop there for now so I can convert this one to the next step for you. See you in a second.